Right into the macular imaging. Starting with fundus fluorescein angiography. As we all know, abnormal fluorescence can be hyperfluorescence, which could be leakage or a staining or pooling, or it could also be hypofluorescence, which can be block fluorescence or capillary non-perfusion areas. Let us see some examples. In diabetic macular edema on fundus fluorescein angiography, we can either get a diffuse DME, which corresponds to a diffuse blood-retinal barrier damage, or we can get a focal DME, where we can see a bunch of microaneurysm in the clinical picture corresponding to the focal leaks. Macular ischemia can be seen as the distortion of the FAS or an enlargement of the FAS. In CNVM, in classic CNVM, we can see early hyperfluorescence due to early leakage, followed by a pooling. In occult CNVM, especially in the fibrovascular PD type, we can see the classical stippled appearance. Central serous choroidal can present as two classical pictures. One is the smokestack appearance, which is seen in 20% of the cases, and the other one is more common one is the in-block appearance. In pseudophakic cystoid macular edema, we can see a typical petalloid appearance in the mid and the late venous phase. Coming to autofluorescence imaging, it is a topographic mapping of the lipofusion pigments in the retinal pigment epithelium with the most dominant fluorophorus A2E fluorophore. There are many techniques of fundus autofluorescence imaging, like the fundus spectrophotometer, the scanning laser ophthalmoscope, or the fundus camera. The advantage of scanning laser ophthalmoscope being it has a confocal mechanism, so it actually avoids the interference from the autofluorescence coming from the lens and the other structures of the eye. Autofluorescence imaging helps us in the early diagnosis of the disease. It helps us to document the progression of the geographical atrophy. In Heredomacular degeneration, it helps in the diagnosis. It also delineates more extensive areas of damage in macular dystrophies rather than the fluorescein angiography. Thus, the advantages of autofluorescence imaging being detection of the early disease and phenotyping. It acts as a predictive marker for the disease. It helps in the monitoring of the disease progression, for the functional correlation with the disease, and it can also help. It can also be used as a future therapeutic applications. Indocyanine green angiography helps in the diagnosis of the choroidal vascular lesions. Its physical characteristics allows visualization through overlying melanin, xanthophyll pigments, and serosanguinous fluid. It doesn't have too many applications nowadays, but in polypoidal choroidal vasculopathy, it is a very important investigation where we can see polyps at the level of the macula. In CNVM, we can see the hotspots. This was more important in the pre-anti-VEGF era, where laser was the main modality of treatment. There are many multimodality imaging systems like the spectralis system, which has advantages like the new proprietary tracking technology, which decreases the amount of artifact, axial resolution being 3.5 micron, and it is much more faster. Above all, it has an enhanced depth imaging, which helps us to image the choroid in a much detailed way, and it also records simultaneously the fundus fluorescein angiography, ICG, OCT, infrared and blue reflectance images. Thus, we can map out the area on the retina properly. Optical coherence tomography, as we all know that it is based on partial coherence interferometry principle. It gives us a detailed view of all the layers of the retina, like the vitreoretinal interface, nerve fiber layer, outer plexiform layer, ELM, ISOS junction, retinal pigment epithelium, and the choroid. It gives us a qualitative and a quantitative analysis of the macula. It gives us a very detailed picture of different types of vitreomacular interface disturbances, like vitreomacular traction, epiretinal membrane, or macular hole. In macular hole, we can also measure the different parameters by which we can actually calculate the indices of macular hole, and we can prognosticate the patient. We can also use this OCT for follow-up. Like here, we can see that there is a return of the foveal contour. The ELM is continuous, but the ISOS junction is still not continuous. In this patient, after 3 months of follow-up after macular hole surgery, still there is a discontinuity in the ISOS and the ELM layer. In age-related macular dystrophy, it helps in the diagnosis and the follow-up. It helps us to confirm the diagnosis, to look for any geographical atrophy, and to follow up the CNVM patients. Like in this patient, in the first patient, after 3 injections of ranibizumab, there is a partial resolution of the fluid. But in the second patient, after the 3 injection of ranibizumab, there is a complete resolution of the fluid. Geographic atrophy can be seen as foveal thinning. In diabetic retinopathy, it helps us to confirm the diagnosis of diabetic macular edema. It helps us to classify the diabetic macular edema, quantify the macular edema, and follow up the patient after anti-VEGF or laser therapy. It also helps us to look for any disturbance in the vitreomacular interfaces. Like in this in this slide, we can see spongiform edema, cystoid macular edema, neurosensory detachment, and a vitreomacular interface disturbance like an ERM. Here we can see 2 types of vitreomacular interface, like a thick dot posterior hyaloid and an ERM. In central serous chororetinopathy, we can either see a neurosensory detachment or a neurosensory detachment with a serous PED, that is the type 2 type of CSR. Just an example, in an optic disc pit with maculopathy, if you take a cut through the optic disc, then we can see the optic disc pit here. Along with it, we can also see a macular schisis and a neurosensory detachment. We can also see in some cases an outer retinal hole. Multifocal electroretinogram, as we can see here, the first wave is a negative wave, and then the second wave is a positive wave. The latency is measured from the time of stimulus to the peak of the P1, and the amplitude is measured from the trough of the N1 to peak of P1. It has many images, but the important being the trace arrays and the 3D response density plots, and the trace arrays at different field like 5 degree, 10 degree, 15 degree, like that. Just 2 examples. In age-related macular dystrophy, here we can see a dip of sensitivity at the macular region. In retinitis pigmentosa, there is a global decrease in the sensitivity. This is a patient who has been treated with stem cell therapy in a case of RP, and here we can see that at 6 months of follow, the sensitivity is a little bit better than the control patients. Thank you.